A good afternoon to all of you who have signed in to watch this panel and take part in this panel. We welcome you here. My name is Molly Grantham. I'm with WBTV News. I anchor the 5 and the 5:30 and the 11, and I am right now in the WBTV building in the upstairs, very quiet sales department where nobody has been for the past, 11 months now, 12 months. So no one should walk in, and then I'll go downstairs and get to work. But I'm really honored to be a part of this panel tonight. This afternoon, excuse me. And thank you guys for signing in. For all of you who are watching, there's over 200 of you to be here to listen, to ask questions, and to hopefully get some information and feel armed with facts when we leave about the science, politics, mistrust, and information surrounding the COVID-19 vaccine. We do want to thank UNC Charlotte, of course, and the Atkins Library's Digital Media Literacy Group for hosting this discussion today. It's really a unique opportunity to have so many smart people, so many experts from different areas on the panel, of which you guys are going to meet all of them. Let's begin with Dr. Zenobia Benefield, an assistant professor in UNC Charlotte's Department of Sociology. If Dr. Benefield, you want to wave, I know everyone sees names, but it's also nice to feel interactive, like we're seeing you and waving to you. Dr. Shi Chen, an assistant professor of health informations and analytics in UNC Charlotte's Department of Public Health Sciences. Dr. Chen, welcome. Dr. Melinda Forthifer, who is a professor of public health sciences at UNC Charlotte. Dr. Cynthia Gibbous, professor in UNC Charlotte's Department of Bioinformatics and Genomics. I'm sorry, it's not either or. Bioinformatics and Genomics. Dr. Gibbous, thank you. And Gibby Harris, Public Health Director of Mecklenburg County, who I always call Dr. Harris, but Gibby, I think we do know that you're just Gibby now in Mecklenburg County to everybody. So thank you, Gibby, Public Health Director of Mecklenburg County. Dr. Kathleen Jordan, Clinical Associate Professor of Nursing at UNC Charlotte. Dr. Jordan, welcome. Dr. Gary Little, Senior Vice President and Chief Medical Officer from Atrium Health, the Greater Charlotte region. Dr. Little, we are so honored you're here. Thank you so much for being here, as we wave to you as well. And finally, Dr. David Wessner, Professor of Biology at Davidson College. So everybody who is logged in, again, over 200 of us watching right now and a part of this panel, just know we've got a really great group of panelists here. So we're going to go ahead and just get started. And Dr. Little, we're going to start with you. And we're going to start with you, Dr. Little, with something that has dominated news headlines for the past few weeks and really put a lot of people on edge. At least I can say that safely from being here in a newsroom and hearing from people on various platforms. It concerns the CDC and the FDA's recommendation to put the Johnson & Johnson vaccine on pause based on reports of a serious side effect, which must be noted was impacted by 6 people so far reported in the United States. So can you describe, Dr. Little, that side effect, the severity of it, and I guess what we should really take away from it, knowing the prevalence of it?
Yeah, so happy to try to tease that apart. It's a pretty complex issue. First, let me say that at this point, we don't know if it's a side effect of the vaccine at this point. What we know is that there have been cases reported of people who've come down with a fairly uncommon or rare blood clotting disease in the veins that drain the brain. It's something that's fairly uncommon. It tends to happen in people who've got underlying, health issues with clotting or some other health issue that causes them to clot. And so in the reports of at least 6 people who had the Johnson & Johnson vaccine within 2 weeks of getting that clotting disease, it really only talks about an association. We don't know at this point if it's a cause and effect or if it's just a coincidence. And I think what I'm really excited about is that our surveillance system seemed to work in terms of picking up 6 cases out of the almost 7 million or so people who received the Johnson & Johnson vaccine here in the U.S. And this, our willingness to be upfront about that, our willingness to share that information with the public, as well as of our clinical people to be on the lookout for additional cases. And so to me, this is an example of transparency in the process of picking up cases and really trying to determine, is this a true side effect, or is there a true cause and effect, or is this just happened to be a coincidence? And I think that's where the CDC and the FDA are really still trying to sort through what is that association. And I think that's why they put it on pause to say, hey, let's hold for now until we get further information. I think it's important that, those 6 cases, and I think there's been a couple more that have been reported. And I think as more of our clinical people learn about this association, they will be on the lookout for it as well. And so, I anticipate there will be some further guidance from the CDC and the FDA on this. It's speculative to say at this point. I think they're trying to sort out if this is a true side effect. Who does it impact? Are there groups of people where the vaccine is still safe? Versus is this just a coincidence that these cases have happened? So, I think right now, I think it's just the story is still being told, and people should just kind of wait and see what our scientists and the data show us.
Well, Dr. Little, in the follow-up to that, if there are people watching right now that got the Johnson & Johnson shot, should they be concerned? And then what symptoms should they look out for?
Yeah, I think in general, people shouldn't be overly concerned. I think it's a chance to just kind of monitor yourself and your body and look for anything that shouldn't be there. And so some of the specific things, obviously a severe headache that just doesn't go away. Any signs of a stroke, so facial drooping, weakness, slurred speech, those kinds of things. Also abdominal pain or pain and swelling in one of your extremities, mostly your legs. Those could be signs of a blood clot. And if you've had a Johnson & Johnson vaccine within the last 3 weeks and you have any of those symptoms, I would recommend you get in to see your doctor or go into to an emergency department to be evaluated.
Okay, Dr. Little, thank you. And we're going to keep on going with some questions again for each panelist, and then this open Q&A for everybody. If you guys have more questions for Dr. Little, Chief Medical Officer for Atrium Health, please put them in chat. And at the end, we'll make sure we get to them. But that's a good explanation, Dr. Little. Thank you. Dr. David Wessner, you are up next, Professor of Biology at Davidson College. You have studied coronavirus pathogenesis as a postdoctoral researcher, and I understand that you've written periodically about the COVID-19 pandemic for Forbes.com. So for the non-experts among us here today, can you describe the science behind the vaccines? How do they work? How are they similar and different? And I know those are big questions, and you probably have a lot of details, answers, but just sort of the overview of how the science of these vaccines work.
Sure, I'd be happy to. And thanks for that introduction. And thanks to the members of UNCC for organizing this panel today. The basic idea behind vaccines is that we introduce into the body something that looks a lot like a pathogen. The body then recognizes it as something foreign, begins mounting an immune response. If you then get infected by the real pathogen at some point later, the immune system is primed and ready to go. So that's the basic idea behind vaccines. The 4 that we're hearing the most about in terms of SARS-CoV-2, the AstraZeneca vaccine, the Johnson & Johnson vaccine, the Moderna and the Pfizer vaccines, take a slightly different approach from vaccines that traditionally we're more familiar with. The Pfizer and Moderna ones both use an mRNA-based platform, whereas the Johnson & Johnson and AstraZeneca ones both use an adenovirus-based platform. For the Moderna and Pfizer ones, the basic idea is there's a nanoparticle that contains the mRNA that codes for the spike protein of SARS-CoV-2. You get injected with that mRNA gets inside your cells. The cells recognize it as mRNA, use it to produce the spike protein. Your immune system then sees that spike protein as something foreign, something different, and begins developing an immune response to it. So again, you get exposed to SARS-CoV-2 at some point in the future, the immune system is ready to go. For Johnson & Johnson and AstraZeneca, again, slightly different approach. They use a recombinant adenovirus. They're taking another virus, adenovirus, splicing into it the gene for the spike protein of SARS-CoV-2. Again, you get injected with those vaccines, that DNA gets inside your cells convert it to RNA, then convert that RNA to protein. The end result is the same. Spike protein is produced, your immune system recognizes it and begins mounting a response.
So for the vaccines, especially the Moderna and Pfizer, they were developed more quickly than most people anticipated. Can you explain how that's possible and how the public can trust the vaccine's safety and effectiveness?
Sure. And again, I've said before, I think the process was fast, but it wasn't rushed. I think those are two very different things. And it's important to remember too that we've had a long history of basic research with coronaviruses. There's been a fairly long history of basic research with this mRNA approach to developing vaccines. Again, coronaviruses have been studied for 50 years. When I was doing my postdoctoral research 20-some years ago, we were looking at the spike protein and how it interacts with cells. So there's a long history of basic research leading us to this point in time. I think it's important to remember too that we've had very good clinical trials of these vaccines. Those trials are ongoing. The trials actually have not been officially completed yet. Both trials of Moderna and Pfizer will be going on until the end of 2022 or the beginning of 2023. So there's been a lot of research leading us to this point. And I think the trials have been very, very thorough, very well-designed trials, getting us to the emergency authorization use that we're seeing today.
Something we keep hearing about is this double-blind medical trial. How do you succinctly explain that to someone, especially with someone who has very little knowledge of the scientific process, the double-blind medical trial?
Yeah, right. A randomized double-blind trial is sort of the gold standard of human trials. And the idea is you have X number of people in a trial. Half of them are going to get a placebo. Half of them are going to get the experimental drug. The double-blind part of it means that the recipient, the patient, is not going to know if he or she received a placebo or an experimental drug. The administrator, the healthcare provider, is not going to know if they're administering a placebo or an experimental drug. And that's set up that way so that any subjective ideas that you may have about your reaction are not being influenced by you actually knowing if you got the placebo or the experimental drug. You get an experimental vaccine, and then you're asked the next day, how do you feel? You may think that because you got the experimental drug, you feel kind of lethargic, whatever it may be. But if it's a double-blind process, you don't know what you've received. The administrator doesn't know what they've administered. That should eliminate that subconscious bias that you might have.
Makes total sense. Thank you, Dr. Wessner. And if you guys have any questions for Dr. Wessner, again, put them in the chat. We'll all see him. And at the end, we'll be able to toss them out to Dr. Wessner and to everybody. Next panelist we want to introduce, Dr. Zenobia Benefield, who is with UNC Charlotte's Department of Sociology. Dr. Benefield, thank you so much for being here. You have an area of expertise, I understand, in health equity, social determinants of health, and health policy. Can you speak why Black Americans are less likely to trust the vaccine than white Americans?
Yeah, I've been asked this question a couple of times over the past year. And it's really interesting when you compare the history first of Black Americans to white Americans, right? And we're talking about the descendants of enslaved Africans. We were brought here by force to be a workforce. When we were unable to be a workforce, we had mass lynchings in the South to exterminate us. When you couldn't exterminate us, there were policies and legislation put in place to suppress and oppress us. And we see these policies still being enacted today. So Black Americans, based on the 400 years of evidence, are very consciously aware that America's policies and institutions do not have their best interests at heart, whether we're talking about education, housing, the penal system, or medicine. And so there is I think, a very warranted concern in believing anything from a country, a government, institutions that have repeatedly shown that we are willing to lie to you, to deceive you, to mislead you, or to outright oppress you if it's in our best interests.
So what do you think then, doctor, is needed to increase trust in the modern medical establishment?
Yeah, that's an excellent question. I think it's interesting. So I teach a course where my students often talk about their concerns that their doctors or the medical establishment in general is more concerned with profits than their own healthcare, right? And these are 19, 20, 21-year-old students, and they're sharing this with me in their work. I think having an establishment that is very transparent in the sense that it is clear that patient outcomes, that people are more important than profits is important. If we look at Johnson and Johnson, for example, the New York Times in 2019 covered the state of Oklahoma suing Johnson and Johnson for their role in the opioid epidemic. And Johnson and Johnson was found guilty for, among many things, purposefully misleading the public on the negative effects of opioids and purposefully misleading the public on the positive effects of opioids, and doing this largely out of greed. And so this information gets added to our cultural knowledge, and we start to understand that these pharmaceutical companies, in cahoots with our physicians and our pharmacists, are putting their own profit margins above what's best for patients. And we've seen Oklahoma, as well as many rural states, suffer tremendously from the acts of these pharmaceutical industries. So, it's important, in order for Americans to trust this institution and these establishments, they must first be trustworthy, right? This is a relationship. And when there is trustworthy action, I think Americans will be much more likely to respond in kind.
There's a lot there. There's a lot to delve into, certainly. And if anyone has questions for you, Dr. Benefield, I hope that they put it in the chat. And again, we're going through them. We do want to keep introducing our panelists. Thank you for that. Next, Ms. Harris, you have served as health director for Mecklenburg County since 2017. You oversee more than 800 public health officials who've been responding directly to this COVID-19 pandemic for the past year. So are you seeing issues, Gibby, and again, I keep saying Gibby because we have you on the news every night, so I feel like we're friends because you're in our homes now every day on TV, but are you seeing similar issues of vaccine mistrust or mistrust of science in general in the local community? Because you're seeing a lot and you're seeing it in all parts of the county.
That's a great question, I think, and Dr. Benefield had a wonderful response to that, and I think she's right on the money. So we do see issues of mistrust. We expected to see those, but you also think about, we've had anti-vaxxers for a long time, and they're not all African Americans or people of color. So there's an issue around vaccinations to begin with. And then the concerns that we've been hearing about, a lot of it just has to do with issues of understanding the importance of the vaccine, issues of understanding information about the vaccine. There's education needed in our community. And the other issue is inaccurate information that's out there, social media, lots of other opportunities for people to put their own thoughts and put their own spins on vaccine. And that's unfortunately having an impact on different populations depending on the information that's out there. So it's a combination of things, I think, that contribute to a mistrust of this vaccine. And it's something that we're combating all the time as we try to get more people vaccinated in Mecklenburg County.
So a similar version of the question that I asked Dr. Benefield would be, how can we help? How do you think we can help our community members understand the importance? You talked about the importance of getting the vaccine and the reasons to continue wearing masks after getting vaccinated.
Absolutely. So one of the things that we need to do is to focus on those folks who just have vaccine hesitancy. There are people who are not going to get the vaccine no matter what we say. Spending a lot of time trying to convince them they need to be vaccinated is not a good use of our time right now. There are a lot of people on the fence, whether that's your family members, whether that's your children, whether that's your parents, whether that's people that you work with. If you have good, solid information about vaccine and can provide that information to them, and support them in their decision making around this, that's going to be very helpful. And the other things that we're doing in the community are trying to make the vaccine as easily accessible as possible. We have more vaccine now available to us. We work with both healthcare systems and with our other vaccinators in the community to make sure that it's just easy for people to access the vaccine. One point I want to make about vaccines, it's a little microcosm when we start talking about herd immunity and why it's important to get this vaccine. Many of our long-term care facilities were targeted for vaccine early on in the process. So late December into January, early February, most of those residents were vaccinated. And we have seen the deaths in long-term care facilities drop to zero. We have not had a death in a long-term care facility until since the end of February. And at one point, they were 60 to 70% of all the deaths in Mecklenburg County. That's huge. So that is a group that is sort of a small evidence of herd immunity, the impact it can have in our community and allowing us to open things up again. So I think, just staying focused on those things and making sure that people really understand that. But in addition to that, we know that no vaccine is 100%. These vaccines are very effective compared to some other vaccines, but they're not 100%. And you don't know whether the person next to you in the grocery store line or at the restaurant or at the bar or wherever you happen to be has been vaccinated. And that's why it's important for you to continue to wear your mask and to avoid large crowds. So those things continue to be important. We are a long way from having herd immunity in Mecklenburg County, so we need to continue to implement those prevention measures that we know work.
When you say a long way, we had some numbers on the news yesterday that came from you at the Mecklenburg County Commission meeting, and I don't remember them exactly, and hopefully you do, but it was something like 70% or 60%, a high number of older people were fully vaccinated, whereas a very small number, I want to say less than 20% of younger people were even partially vaccinated. So how does that play a role? Because herd immunity is everybody, right?
It is everybody.
Go ahead, I'm sorry.
Yeah, one of the things we're looking at right now is not just the total population, but the total population that's eligible for vaccines. So we have a whole chunk right now of children under the age of 16 that aren't eligible at the moment. We're hoping that's going to change soon. But it's those folks that are eligible that we really need to get vaccinated. Many of our younger population have only been eligible for vaccination for a couple of weeks now. So we know we've still got work to do there. But what we're seeing is a lack of urgency in that population. It's not that they don't think about getting vaccinated. It's just that if it's not convenient, then they're not going to take the time to make an appointment and go somewhere to get vaccinated and have to go back for a second dose.
May I ask you specifically what that age group is? Is it 20 somethings? Is it 20 to 45? Like, what is that age group?
It's 20 to the 35, 40 age range. It's still got a long way to go to get vaccinated.
Okay. And final question for you, Ms. Harris. Right now in the preliminary part of meeting the panelists, we have a lot of questions here, and I think you guys have heard this as well, but what are their guidelines, if there are any, in place at this point for high-risk individuals to be able to return to work without wearing a mask?
So actually, we're not recommending anybody return to work without wearing a mask at this point, even if you've been vaccinated. We are still under a mask mandate in North Carolina and in Mecklenburg County. So if you're outside of your home, you should be wearing a mask. There's still a lot of virus in our community. There's still a lot of people who haven't been vaccinated. And you can't tell by looking at somebody whether they've been vaccinated or not, or whether they may have COVID, especially with the percentages of people who still are asymptomatic when they're infected. So yeah, I would anticipate that we're going to be wearing masks for a while, even in the workplace.
Okay, thank you, Ms. Harris. Dr. Chen, you're up next to have everybody meet Dr. Shi Chen, and you are with the UNC Charlotte's Department of Public Health Sciences, and you have research interests, I understand, Dr. Chen, that include data analysis and modeling of infectious disease, as well as health misinformation dissemination on social media. Whew, that is a big thing to delve into, social media and misinformation. Can you comment, even in a generic way here, because I guarantee you'll have more questions on the role of social media in spreading disinformation and misinformation, particularly about the COVID-19 vaccine?
Oh, yes, thanks for the question. So social media have been regarded as some kind of a double-edged sword for both disseminating useful and effective information during a health emergency, as well as disseminating the misinformation and disinformation. So I think traditionally, when we think about misinformation, it's basically mouse to ear, but for social media, it's actually many mouses and a pair of ears. So that's we kind of overload and over bombarded with information, and even with some small percentage of misinformation. So the social media gives almost like a greenhouse to its fast pace and a large coverage of the audience makes it a kind of ideal platform for misinformation to infiltrate and proliferate on the social media, and eventually, unfortunately, sometimes outcompete the real and useful information on social media. And I'm so amazed that like 140 characters on Twitter, now it's 280, can incorporate so much information. And unfortunately, sometimes the COVID-19 vaccine is not the main focus. They are misinformation, use this to distract the public, awareness and perceptions to some other issues like genetic modified organism, GMO, like the conspiracy theory about big pharma and this type of things. So, I mean, social media is a technological platform, but it is unfortunately, because of its own characteristics, it can be a warm bed for the misinformation. So we need to be really, really careful about what we share and what we see on the social media.
So some people with social media intentionally try to be evil and put out misinformation or disinformation and share that, right? But a lot of people, some do, but a lot of people I think have good intentions in believing it and thinking they're helping their friends by sharing it. So what is some advice or some ways that you think people can avoid sharing vaccine misinformation on social media?
That's a great question. So I think it is actually the entire society's efforts to actually at least reduce the spread of the misinformation. So for researchers, we need to be doing more research and being more transparent about the effectiveness and the efficacy of the vaccines, especially for us, like we are teachers, we're instructors. So we need to increase the health literacy in our community. For instance, in my class, I teach my undergrad students about, for instance, those kind of important, but sometimes a little bit complicated concepts like what is herd immunity? How do you measure it? What is basic reproduction number? What is association between herd immunity and the basic reproduction number? What is some kind of, some misconceptions of the herd immunity? So this kind of things, I think if we instructors can give more instructions and increase the literacy of the individuals in the society, they can be the seedlings to disseminate the real and useful information and ban the angle of this misinformation, vaccine misinformation epidemic as well. And lastly, for the general public who do not have a very comprehensive understanding, I think it's our we need to do our due diligence and do our homework. Think a little bit more before we hit the share button, and do a little bit more homework. See where this information sent out. Is the original sender verified? Is it verified information? Is this user is verified? Is there any potential conflict of interest? This type of things. So if everyone in the society, everyone on social media can do some part of the work, then I think we can at least reduce the harm of the vaccine-related misinformation during this pandemic.
Dr. Chen, thank you. It is sometimes the wild, wild west out there with social media. So anyone else with questions for Dr. Chen, please put them in chat. And our next panelist to introduce you guys to is Dr. Melinda Forthover. Your research, let me say again, you are with the Professor of Public Health Sciences at UNC Charlotte. Dr. Forthover, your research focuses on social factors relating to health behavior change in diverse community settings. So how does misinformation about the COVID-19 vaccine and pandemic compare to misinformation during previous health crises?
Thanks, Molly. So when we think about these previous health crises, I can go back maybe 75 years and think about some that many members of our population did not even live through. But for example, controversy over a drug called thalidomide, which was used to treat morning sickness originally, but caused significant birth defects, or DDT, which was a pesticide that created a lot of health risk. Or even the HIV/AIDS pandemic, which is, to some extent still a pandemic today. If you think in more contemporary terms, we have the public health crisis around gun violence, or the Flint, Michigan water crisis, or the obesity epidemic in the United States. And what I think all of these crises have in common when we look back at them historically and when we reflect on what we've seen with the COVID pandemic is that it takes time in our society for an emerging health threat to be viewed through a widespread consensus as an actual public health issue. And when I say that, part of what I mean is that I'm getting at public health's really core objective. The thing that separates public health from medicine or nursing or any other aspect of science is the core objective around promoting the population's health, the entire populations, not the individuals. And so when we're looking at an issue that seems to have a widespread impact on and a threat for the population's health, it can take some time for people to see that evidence, to understand how widespread that threat might be, and to really galvanize support in a society around doing the things that we need to do to eradicate that problem. And we are still early in that timeline when it comes to the COVID pandemic. But I don't think that what we're seeing here is necessarily a different phenomenon. What we are seeing, I think, is that it's more challenging because of some other things that are going on because we're a modern society. And so that includes the rise of very polarizing partisanship around political issues, the rise of digital communication like social media and the kinds of dynamics that Dr. Chen was speaking about. The fact that we have a 24-hour news cycle. And so things happen so rapidly that people are often reacting to a tidbit of news before there's really been time to process the whole story. And just in general, with all of those modern trends comes a tremendous need for our society to have information literacy, and more specifically, media literacy, and even more specifically, digital media literacy.
There's a lot there. So how has misinformation, in your opinion, about the COVID-19 and the vaccines impacted different communities' behaviors? So we know the misinformation's out there, and we've talked about how it gets out there, but how has it actually cause and effect impacted behaviors that you've seen in various communities?
So obviously the word communities is plural, and I think it's important to recognize that we have many different types of communities who are being impacted right now. When we see a lot of politicization of issues, we have seen evidence of people feeling pressured to align their political ideologies with their health behaviors. So for example, if political leaders are saying that the virus is a hoax, then people who feel pressure to align their ideologies in support of that leader with their behaviors around the vaccine or the virus may struggle to follow public health recommendations. There has been a politicization of the idea of individual freedoms versus population health when it comes to things like staying home and mask wearing. We also have a significant amount of hegemony in the initial US government's pandemic response. And some examples of that include labeling the virus as quote unquote, the China virus, shunning the World Health Organization's efforts and initial warnings about the virus, and even some initial denial or concealment of data that the virus was already spreading in the US well before there were travel restrictions placed on entering the US. So those are all dynamics that pit groups against one another. They're divisive. They create an us versus them dynamic, and quite legitimately lead to fear and seclusion among immigrant groups, Black, Indigent, and people of color. I mean, it just creates a dynamic in which people fear scapegoating, discrimination, etc. And then the third piece of it, I think, is that our COVID-19 pandemic has coincided temporally or historically with a very powerful social justice movement in the United States. And that has created situations in which we have tremendous pressures on essential workers to continue doing the things to help our society keep moving along, delivery people, UPS drivers, healthcare workers. Many of these individuals are more likely to be Black, Indigent, or persons of color. Many of them are more likely to be in lower paying shift jobs, and they are also likely to have underlying chronic conditions. And so we have a situation in which people who may already have some mistrust of systems because of the kinds of dynamics that my colleague Dr. Benefield mentioned, they're carrying out really essential roles in our economy and in our workplace, but doing so with tremendous individual risk for themselves. And that has created some real significant dynamics that cause people to feel at risk. I think it's important to remember that when we talk about BIPOC communities, and by that again, I mean Black, Indigent, and persons of color, the mistrust of systems is not new. And there are a number of historical abuses that have certainly been hallmarks of why distrust occurs. But the patterns are maintained every day by the systemic discrimination that still exists in our society. So, and in public health, we often teach our students about the Tuskegee study and what happened there that created mistrust for some individuals. But the mistrust that we see in these populations today is very unlikely to be due to something that happened that long ago. It's due to experiences that these individuals live every single day and that we need to continue to try to address.
That's all really important, very important. On a slightly more positive note, have you seen any community outreach that's worked, been effective at disarming the misinformation?
So I think it's really important to remember that a great deal of what we see in a positive level about health is local. It's incredibly local. So people are more likely to trust those who are familiar to them or who they perceive to have a similar perspective and who will understand their needs or concerns. And so the more that we can use familiar channels. So for example, Molly, people see you on the news and they feel they know you. And so there is an influence that you can have as a familiar face that perhaps I as a scientist cannot have. And so that's important to understand. It's also important to think about all the different layers in which people receive information and all of the issues that are logistical barriers to receiving the vaccine. And I think Gibby Harris talked about just all of the layers of convenience and access for someone to get off that fence, that proverbial fence, and decide to receive the vaccine. And so that means things like employers supporting workers with schedule flexibility, paid leave if possible, support in navigating appointment scheduling. I mean, those of us who are on this panel spend an absurd amount of our lives on the computer, but not everyone does that. And for not everyone we know in our social networks is comfortable using a healthcare system's internet portal to schedule an appointment, for example. And also I worry about things like childcare and transportation. If you're booking an appointment for a vaccine that's 3 weeks out, you may not know if you'll have childcare or transportation on the day of that appointment. And so the things that seem to be working are the things that capitalize on trusted local channels of information and then removing as many of those logistical barriers as possible.
Well, just so you know, happy to be here if it makes any impact at all at helping disseminate the proper information. So all volunteer effort this morning to be here. And I think a lot of people, at least in my field of news, people might argue that, but there's a lot of really good people and reporters that want to get out the proper and right information. So happy to do that. And let me just make sure you said about making an appointment. And Ms. Harris, all the walk-in appointments in Mecklenburg County, all the clinics now are walk-in, right? For vaccine?
Absolutely. As far as we know, all of the providers are making walk-ins available. There are still appointments that you can make if that works better for you and your scheduling. But at the same time, every clinic that we have, and I believe the healthcare systems are in the same situation, we have sufficient vaccine that we are allowing for walk-ins and are recommending that people access this vaccine wherever they can.
And Dr. Little, do you know that to be true for Atrium? Putting you on the spot here with that, but just to make sure that if people.
Yeah, I think it's to a certain extent, like as Gibby said, most of our access is appointment driven. And again, that just, allows us to make sure we've got enough vaccine for who wants it. But more and more as we were getting more vaccine from the state, we are adding on walk-up appointments to those, or walk-up access to those venues as well. And then we have some that are strictly walk-up. So getting to some of those vulnerable communities, those are targeted and specifically no appointment needed to kind of remove that as a barrier. So it depends on what we're doing,
Right.
but more and more we're adding more just walk-up access. And additionally, we're going to start going to places like malls and ball games and other places where people are, and just setting up there and saying, okay, we're here with vaccine. If you want one, come get it. That's just a shift in what we're doing.
That's really interesting. Now the supply is here, make sure we still have the demand to get it. Thank you. I want to get back to going into meeting the panelists, but I didn't want that to go unsaid because that was just something that happened yesterday that we'd heard from the County Commission's meeting that it's now walk-in appointments to all these places, and Bojangles Coliseum is going to shut down May 22nd. Right. Okay. Just make sure we all had that information. If you have more questions for Dr. Forthifer, thank you so much. That was great. Our next panelist, please put them in chat. We're getting a bunch of questions in chat. They're really good questions and I want to make sure we get to them. So we're going to keep moving here. Dr. Cynthia Gibbous, she is a professor in UNC Charlotte's Department of Bioinformatics and Genomics. Just tell me, Dr. Gibbous, how do I pronounce your title of the department you're in? Genomics?
Genomics, yes.
Okay, good. Thank you for laughing at me. I appreciate that. Actually, I deserve that. So, okay, you have been leading, though, sequencing efforts on campus to identify variants detected, which is fascinating. So can you describe the surveillance sequencing and how one would do that? I mean, how do you even find the trends of variants showing up in North and South Carolina?
Well, so on our campus, we have a testing center. And what we do for our local group, and we're only sequencing from the UNC Charlotte campus at this time, we have the test center extract genomic material from their viral samples. And that comes over to our lab. And we do a few complicated lab chemistry things called making a library. And we have a sequencing instrument that is capable of sequencing really, the limit is thousands of genomes at the same time. With the staff we currently have, we're doing about 100 a week. But so how does that work? So when we talk about genomes, everybody's got a genome. We have genomes, the virus has a genome, everything in between. And in our case, that's DNA. In the virus's case, it's RNA. Those are strings of nucleic acids. They're little chemicals that form a polymer chain. And so it's a big, long string of information. And what our sequencer can do is it has a kind of something called a chip or a flow cell. And the function of that flow cell, it has little pores that pull that sequence through, and it reads those nucleotides in order. And we do that over and over and over again. So every sample gets sequenced through thousands of times. Okay, so it's not just, we see it once and then we say, oh, there's a variant there. We copy over that sequence thousands of times. So by the time we get to saying, oh, well, this sequence has this particular variant, we are sure of what that sequence is. So then, there's a big scientific effort to categorize all of these variants. And there have been people working on this from the beginning, basically following the family tree of the virus, right? So every time a virus replicates itself, there's a chance that it'll make an error, that one of those nucleotides will change in the copied virus. And that virus goes off and forms its own lineage and keeps changing. The original one keeps changing in a different direction. So when we start talking about variants that we see across the world, we're talking about a pattern of differences that distinguishes these lineages. And so a lineage that you guys are probably familiar with hearing, because it's on the news all the time, is B117, or other times they'll call it the UK strain of the virus. And the thing that distinguishes that strain of the virus is that it is much more highly transmissible than the original viral strains. And that's because it has one or two different key changes in its genome that make the proteins a little bit different, make the spike protein a little bit different, and it is better able to attack your cells, okay? And so when we see that particular combination of nucleic acids, that particular pattern in the sequence that goes with that lineage, then we say, okay, we have B117. And the chancellor, of course, of UNC Charlotte said, in an email to the community, that we have variants on campus a couple of weeks ago. And so that's the main one that we're seeing. And I can also go out, there's public databases where the research community is collecting virus sequences that have been generated at other institutions or by the CDC. And so I can get all of those sequences from North and South Carolina. I can download them and I can run them through the classifier and say, well, what are these? And so when I look at those sequences, even from the last few days, well, what's really happening here is that we're seeing a lot more of that B117 lineage in the samples that are getting sequenced, okay? The only problem with that is that we're not sequencing nearly enough to know what's really out there. And that's a national problem. The president has recognized that as a priority. They have just put in, a very large amount of money to be distributed to the CDC and other institutions to do more sequencing so that we can get a better handle on what's going on with this virus. And, the important thing to know, I would say, for just the public to know about these variants is that some of them are troublesome, right? They might be able to evade our antibodies a little bit better. They might make us a little sicker, or they might transmit easier, but all of them are going to be slowed down if you get vaccinated. Okay, so even if one of these mutations has happened and it's made the virus a little bit less susceptible to antibodies that you have from a previous infection or from being vaccinated, having those antibodies is better than not having them. Okay, so that's, I know people are concerned and they hear this is a topic around which there's a lot of hype, media hype, where, oh, new variant, we got to worry about this one. Well, is it really in your area? If it comes to your area, is it really going to make things worse? Or, what are you able to do about it? That will change, those strategies change depending on what variants you're seeing, but the vaccine is always going to be a good idea, no matter what's going on with variants locally.
So Dr. Gibbison, an overarching view for those of us watching this panel right now and aren't as scientifically adept. Okay, so how can we better educate ourselves basically on how the viral variants work? So when disinformation and misinformation is put, let's say on our Facebook feed or online, we know that that's not true.
Okay, well, there's, I think, a lot of scientific studies get blown out of proportion, right? So when something is newly discovered and for instance, you hear, oh, well, this strain from South Africa is coming and the antibodies really don't work against it. The vaccine isn't going to work against it. you would always take a claim like that with a grain of salt. And the best thing that you can do as a member of the public is look for news sources that are going to give you more details. So, the New York Times does a good job of actually talking about what does it mean that this virus, this variant of the virus has a 5% chance of evading the antibodies, or a 10% chance of evading the antibodies, or it's, you want to have that scientific study put into perspective, so that you don't just say, oh, well, reduced efficacy, that means it just doesn't work at all. And that's where I see the most misinformation surrounding the variants, is that people assume that, oh, well, it reduces the efficacy of the antibodies just a little bit. And then they assume that that means that nothing we do will help, right? And that it's hopeless against that variant. And that's just not true.
Okay, that's good, Dr. Givas. Thank you. Our final panelist to introduce, and we have some great questions here we're going to make sure we get time to get to. Dr. Kathleen Jordan, who is a clinical associate professor of nursing at UNC Charlotte. And Dr. Jordan, your question, some of the questions we were thinking about for you become a little bit more emotional, because you've served as a frontline direct care provider during the pandemic. And I just wanted to ask if you could share a little bit about what that experience has been like over the past year.
Thank you, Molly, and thank you for including me today. I bring a little bit of a different perspective. I am a frontline provider. I'm a board certified emergency nurse practitioner, and I work in one of our very big and busy emergency departments in Charlotte. And as all of you know who have been in an emergency department setting, we work and it's busy, it's unpredictable, and it's chaotic. Luckily, I work with a very amazing, supportive, and knowledgeable and highly skilled team, and we love what we do, or we wouldn't be there. I have been in this environment for over 30 years, and I still love what we do. As emergency department providers, our culture is one of strength and resilience. We feel very confident in caring for any patient that comes through our door, regardless of this injury or illness that they've sustained. And I believe we give excellent care in emergency medicine. And then came COVID, and everything changed. Our clinical practice changed. Our standard operating procedures changed. From the very, very beginning, we were faced with this perplexing and challenging medical mystery. And for the first time, we didn't know the answers. We didn't know the answers to basic questions. And we're used to knowing the answers and knowing what to do. So we didn't know how aggressive this disease was. We didn't know how contagious this disease was. And then our work hours became longer and longer. And for 14 or 16 hours, we were covered from head to toe in layers of PPE. And for those of you that have not worn PPE, it's hot and it's uncomfortable, especially when you're layered. Our work hours were longer. Our patients were sicker. We had diseases that we weren't familiar with taking care of. We had patients that were young and previously healthy that we were intubating and putting in a prone position and trying to save their life. We had parents and grandparents and children that were anxious, that were fearful. And for us, we had our colleagues that we saw get ill with COVID. So we were covering more and more shifts. So our anxiety and our fear escalated. And it doesn't go just for emergency providers. This includes the whole team. Our housekeepers had to go into a room where a known COVID patient was and clean that room. Dietary had to serve meals to these patients. So we walked out after a very, very long, stressful day to our families. And our families were scared. Our friends were scared. Many providers with small children told me that their kids would cry themselves to sleep at night, worried that mommy or daddy was going to get the virus and they were going to die. Yes, in all transparency, we did take a mental, physical, and emotional toll. However, we remained hopeful, we remained strong, and we remained resilient. And then we got the message. We trusted science. We trusted our leadership. And in mid-December, we all stood together with our sleeves rolled up, high-fiving each other with smiles on our face as we received the first vaccine.
how does your experience, those are such great details, so descriptive, Dr. Jordan, but how does that experience in your mind then impact how critical it is for everyone to get the vaccine? Or if people feel comfortable with getting the vaccine, how important is it knowing what you know?
COVID is not gone. I take care of patients that have COVID or what we call PUIs, people under investigation for COVID, every time I work a shift. And we have to help our patients and families learn to trust science and trust leadership. When I met with a group of my colleagues, I said, what message can I give to the community from us as emergency care providers, as frontline providers? And we had a small group. They were paramedics, they were nurses. We had some social workers, we had providers. And I'm going to read you the message. And this goes out to our community. Love me and my family and every healthcare provider. Love us enough to get vaccinated. We have selflessly kept you safe. Now it is your turn. Do your part, trust science, trust our leadership, and not only keep yourself safe, but please keep us safe and healthy too. So that's a message from the emergency department.
The frontline direct care workers. That is our panel. Dr. Jordan, thank you. We have like 20 plus questions that are all in depth and really, really good in our chat right now. So we're going to start going through them. We made sure to leave at least half an hour. And if we don't get to your question, we're going to make sure our team of people is answering you, so you will get an answer somehow. So put it in chat if you have a question. We have such experts on here. It's amazing how much information and how much knowledge is on here. I want to start with a question though, from someone who's it's a very personal question. It was one of the first ones that came in because obviously they are concerned, and it's for you, Dr. Little. It is someone with an email address at uncc.edu. So they're connected to the college, and they said, I had the Johnson & Johnson vaccine on March 14th. I recently had a nosebleed that was really bad. 2 weeks ago yesterday, I called my doctor's office. I was instructed to email my doctor with my concerns. The response I received was it was probably related to allergy season. Since it's been over a month and I haven't had any other symptoms, should I still seek medical advice? And this question is so important because anybody who had the Johnson & Johnson vaccine might be heightening some of the symptoms they could be having from something that is just allergies because they are concerned because of the headlines. What do you say to him, Dr. Little?
Yeah, I think the difficult to answer with, without sort of giving medical advice, which, I'm not in a position to, evaluate this person and ask questions and then examine them. So what I would say is they did what they should have done, which is I'm having something funny happening that doesn't typically happen to me. And they reached out to their physician who made a determination, and I don't know what information their physician used to make a diagnosis that this was related to allergies, but I got to assume that they use what we all use, which is a good history and hopefully a physical exam. What I would say is if they are still concerned that at the time their doctor attributed this to allergies, and now with this new information about this potential association, that they recontact their doctor to be reevaluated. That would be my best advice at this time.
Okay. Dr. Little, thank you. This was a question to anyone that wants to answer it with the medical background. If a booster shot is required in the fall, which we didn't even get into, right? We're anticipating that we might need boosters for both the Moderna and Pfizer vaccines. Is it best to wait until then to get vaccinated? Gibby's shaking her head no. You want to answer that, Gibby?
Absolutely. We need people to be vaccinated now. We have virus in our community now. This may very well look like a flu vaccine as we move forward. We don't know exactly what's going to happen with this. They're still doing research on how effective and how long this vaccines will provide the immunity that we need, but the antibodies that we need. But we need people to be vaccinated now to protect our community. So they should not wait until the fall to see if they may need a booster.
Good short answer. We like that.
Yeah,
Just
I would agree with Gibby and just add, if you wait until then, it's not a booster, right? A booster means you've been vaccinated and then you get another dose at the end. And we don't know when the CDC or FDA is going to recommend or approve of a second or, a subsequent booster dose. So I think it's presumptive to say it will be in the fall or winter. We don't know what the future holds. I think right now we are still in the midst of a pandemic with rising cases. We need everybody to get vaccinated who can.
Dr. Wessner, this one's for you from Ray. If the type of virus has been around for a long time, what makes this one different from ones in the past?
There's the whole group of viruses that we categorize as coronaviruses that all look a little bit different. So there's several that have been in the human population for a number of years. They bizarre names, OC43, 229E. There's others that have emerged, have entered the human population relatively recently. The first SARS-CoV-1 in the early 2000s, MERS-CoV around 2013. So this new virus, SARS-CoV-2, is in that coronavirus family, but had not previously been in the human population. I mean, presumably it entered the human population through zoonotic transfer from an animal, a bat perhaps, or an intermediate animal. So it is within that general group of coronaviruses, but it's distinct from the others that we've seen before in the human population.
Dr. Wessner, Andy also asked that when you originally talked, you mentioned immunity from the virus and your own body's immune system. So if you already had COVID-19, people are wondering, should you get vaccinated and why? And that kind of goes to the antibodies that were all over headlines about if you had COVID, you couldn't get it again, which no one really knew if that was true, right?
Right. Yeah, the recommendations are, even if you had COVID previously, you should get vaccinated. We don't know how long the antibody response lasts. There's some evidence that you can get reinfected if you've had the initial infection. So yes, the recommendations are, even if you have had COVID-19, you should get the vaccines that are available now.
So Jennifer then asked also on that same line, and it was about immunity. And Jennifer, you had a lot of questions in here in the chat, but I'm taking the middle part of your question here. If someone is asymptomatic but could still spread and infect others, first of all, is that true? If you're asymptomatic, could you still spread and infect others?
Yes, yeah, if you're asymptomatic, you can spread the virus, yes.
Just wanted to make sure we're asking that, so I'm not acting as if it's truth and people can trust you, not me. What is being done then, she asks, to evaluate this? Because the perception, Jennifer says, being provided to the public from multiple industries is that if you get the vaccine, you won't get sick or spread it if you're around a COVID person.
Yeah, I think it's worth talking a little bit about the initial trials that have occurred. We're looking at disease, looking at COVID-19, the development of COVID-19. They weren't initially looking at, are you actually getting infected? So we know these vaccines are very effective in preventing disease. We don't know yet if they're effective at preventing infection. So you could get the vaccine, you're largely not going to get severe COVID disease, but you could get infected, have an asymptomatic infection and spread the virus to others. That question is being actively addressed now. The studies are ongoing now to see if, in fact, the vaccine decreases the risk of becoming infected with the virus.
Okay. Dr. Harris, this one is for you from Megan. You said that you stated about people are on the fence about getting the vaccine, which I think we all know, and that you said that they should be encouraged to get it. What specifically, Megan wants to know, could be said to those individuals to get them to get the vaccine after all?
I think first you need to understand why that individual is hesitant, and that varies from person to person. It's not the same for everyone. If you understand what their hesitancy is, then hopefully good, strong, accurate information can be provided. The information is out there. You need a trusted source where you go for that information. I'd like to think that the county health department is a trusted source, but we know that's not always the case. CDC, not always the case. The state, not always the case, but we try to make sure that the information we put out there is accurate, that it is scientifically sound. And so going to those websites, making sure that you fully understand the situation, but also having conversation with your provider to let them help you understand the benefit of the vaccine and address any concerns that you have about it. It's helpful for people to have the opportunity to talk through it and to work through the particular issues that they have. But at the same time, making sure that people are looking to good, solid sources for information and not just reading anything and everything that's out there on Facebook or social media these days, because there's a lot out there and a lot of it is inaccurate.
Dr. Benefield, I want to ask that same question to you. It was for Ms. Harris, because she said about the being on the fence, but you talked a lot about the difference in communities and the perception of things and a historical importance of not wanting to have to get a vaccine. What would you encourage people to say specifically to friends that say that they're hesitant, and why?
Well, I would echo a lot of what Gibby shared. It's really important that you talk to your healthcare provider. I think this is where continuity of care comes in, because if you have a relationship with your healthcare provider and you've been seeing them for a while, you may be more likely to trust them as opposed to a healthcare worker who you've just met, and having very honest conversations about your concerns, about your needs, and bringing those cultural aspects into the conversation. And hopefully your healthcare provider is educated enough to be able to put your healthcare into context. So conversations with people who are experts, I cannot sort of emphasize that enough. Expertise is really important here. And lay experts and social media experts do not count. People who have dedicated their lives to studying this and who have a dedication to the objective presentation of facts. Who are not trying to politically sway you, but who are just very much interested in the numbers. I'm a researcher, I present numbers, and I have you interpret them as you see fit. And so if you can find someone in your network who is that person, go to them, trust them, and have the conversations that you need.
Thank you, Dr. Benfield, that's great. This is for someone with UNC Charlotte. Someone from UNC Charlotte asked, will we be required to have the vaccine in order to attend UNCC?
So at present, the university has said that they will not be requiring the vaccine. The university is encouraging people to document whether they have the vaccine so that they can be exempted from a daily survey and possibly some of the random testing protocols that are in place.
Beth asked, do you think we'll be able to get the vaccine to family physician providers since they are more trusted? I'm not sure, Gibby, if that's you or someone else, but I know Dr. Little, you said maybe from Atrium going into like ball games and events where lots of people are. That's fascinating to me. Do you think they'll be able to get the vaccine to family physician providers?
So I'll start with that, and then I'll punt it to Dr. Little. So we have been working for several months now to help providers across the county become eligible to receive vaccine and to provide vaccine. One of the challenges we have with that is the multi-dose vials that a lot of these vaccines come in, and there's a lot of encouragement happening at the national level for the vaccine providers to start going to single dose vials, which will make it much easier in physicians' offices. But yes, especially as we start looking at our younger populations being eligible, we really expect them to be getting a lot of that vaccine through pediatric offices, through their doctor's offices. And again, this goes back to making the vaccine readily available across the community. And I agree with Dr. Little, going to people where they are. We're actually having conversations with a couple of breweries and bars right now who are interested in supporting vaccine clinics, a number of other businesses that are interested in vaccine clinics. So I think there's lots of opportunity out there.
That's fascinating too. Dr. Little, do you have anything to add to that?
Yeah, I think Gibby's right. Some of the limitations of the vaccines themselves. So one, limitation of the amount of vaccine, two, storage requirements, and the fact that because it was such a limited resource, we never wanted to waste not a single dose. And with these multi-dose vials, you had to use them once you punctured it within a certain period of time. And so if you didn't have enough people to give it to, you could potentially waste vaccine, which we didn't want to do. As we're getting more vaccine, the ability now to put it into doctors' offices and, where wastage may not be the worst outcome, but getting it to people in different settings is really now more the priority. But those storage concerns still exist, so we have to work through those. But I think more and more doctors' offices will begin to have them. We are doing some of our doctors' offices on limited basis, really in places where access is needed right now. So for instance, Rutherford County, we have a clinic there, and we've been giving vaccine through our doctor's office out there. So I think that will expand more and more as we get more and more vaccine.
This question is very scientific based, and it is for Dr. Gibbous specifically. If the variants delete, substitute, or replace parts of the genome and that modifies the spike protein, how is that the Pfizer vaccine seems to do better against these variants, or am I wrong on this?
So the spike protein is the very characteristic outside of the virus, and the one that the Pfizer vaccine and the Moderna vaccine both target. So when those vaccines put the mRNA is injected into you, that piece of mRNA is actually turned into a spike protein by your own body's machinery and becomes the spike protein that your antibodies learn to attack. So if the spike protein were to change a lot in shape because of a mutation or a deletion, that's what could interfere with the efficiency of the vaccines. But there's a lot of research that suggests that the spike protein doesn't have that much structural freedom to change. The molecules of that protein, the atoms of that protein, have to be packed together in specific ways to make that protein shape. And a mutation that takes it too far from that is actually going to be disadvantageous to the virus, or maybe it won't be able to make that protein at all. So right now, the best information that I have about that from current research is that scientists who are studying this believe that some mutations are just very unlikely to happen. You're unlikely to have a virus that makes a spike protein that is so different from the basic original spike protein that the antibodies would not recognize that. Okay. I hope that helped. I know that was deeply nerdy.
Okay, no, a lot of people on this call. There again, over 200 people registered, and a lot of people have different questions. This one is for Dr. Jordan. Dr. Jordan, can you explain how a vaccine still in trial is considered safe enough for emergency use?
Well, I know from science, and I'll ask the scientists on the panel to back me up, that what we know is that the vaccines were evaluated in tens of thousands of clinical trial. They've undergone scientific, rigorous research for safety, effectiveness, and the manufacturing quality, and they've met the standards for emergency use authorization. And I
was gonna say, is there anyone else that wants to add to that?
And again, we have to trust science.
Yeah, I think it's a great question, and it sort of, again, speaks to context matters, right? We're in the midst of a pandemic, and over 500,000 people have died thus far. And basically our system has said, because of that, we have sort of a minimum standard that these manufacturers have to meet to show that the vaccine is safe and effective. And so that's where that emergency use authorization comes in. If we were not in the midst of a pandemic and there weren't people dying daily because of it, then the trials would need to go through the full approval process that the FDA normally has. But basically, when you have something like this, the FDA and the policymakers and the CDC and their advisory people are saying, if we don't do something, this is going to just cripple and kill millions of people. We've got to do something to stop the tide of death that's happening from this virus.
I think something else about being in the middle of a pandemic and how fast this vaccine moved is actually important for people to understand. So I was actually in the Pfizer clinical trial, full disclosure, and it was a very large trial. It was something like 49,000 people. And the reason that they could tell so quickly that this vaccine was effective is that so many people were getting infected. So when you have a vaccine trial and people are being challenged who have been vaccinated in the trial are being challenged by the potential of infection constantly, you can tell much quicker that something different is happening with the control group than with the group that got the vaccine. And so that is part of why these vaccines were able to get that emergency use authorization level of proof so quickly, is because so many people were getting sick.
So because you admitted you're in the trial, I'm going to ask this question now. Somebody asked, if you feel comfortable through all the panelists, will you say what vaccine you got if you got one? And of course, there's no requirement to say if you got it or not, or which one. But I take it, Dr. Gibbous, you were Pfizer, because then you were the Pfizer.
Well, yes, and I got the placebo originally.
Oh, and then did you go back and get one if you feel comfortable?
And yes, and then so I run the wastewater testing lab along with sequencing at UNC Charlotte. So we actually got classified as 1A because we're exposed to wastewater all the time and there was a chance of infection. So I got mine back in January and got the Pfizer vaccine because they made me do that because I was in the trial.
Does anybody else want to unmute themselves and say what vaccine they got, if they got one, if they feel comfortable announcing it?
I got the Pfizer and I got it very early. I was mid-December.
I got the Pfizer as well.
I got the Moderna one.
I got the Moderna one. I will add that I would have happily received any of the vaccines that were approved at the time. And I actually, at the time, hoped I could get the Johnson & Johnson because I thought the one-shot option was very convenient.
So there, whoever asked that question, there you go. Everyone's sort of being open book and transparent. I got the Pfizer one too. Not that anyone cares what I got. I'm not the scientist, but I did. I got the Pfizer. From K-Hop, what are the panelists' thoughts about teenagers over 16 who have autoimmune diseases getting the vaccine? Is there a vaccine manufacturer that is recommended for those kids? Does anyone want to take that? Teenagers over 16 who have autoimmune diseases getting the vaccine. Is there a vaccine manufacturer recommended for those kids, or are any of them okay? And would you recommend children with autoimmune diseases to get it?
This is a hard one. Well, right now, the only vaccine that's approved for kids 16 and 17-year-old is the Pfizer vaccine. So if you're 16 or 17, that's the only one you can get right now. 18 and over, you can get the Moderna, and if the Johnson & Johnson, depending on what they say about that one, but previously it had authorization for 18 and above. My guess is they're asking about autoimmune disease, and specifically, are there any concerns or issues with getting any of the vaccines? And what I would say is, under the emergency use authorization, there are very few restrictions to getting any of the vaccines. They really boil down to if you've had an allergy to one of the substances in the vaccine, or if you've had a previous reaction to the vaccine itself. Those are really the only restrictions to getting the vaccine. And what we've advised people to do who have an underlying health condition with concerns is to speak with their physician and really so that person can really help you make the decision that's right for you.
Does anyone else want to add to that? We have a lot of questions. We can keep going. I know if you said it's tricky, it is tricky. It's each person sometimes. There have been a lot of questions. So I guess this would be Dr. Little, you or Dr. Jordan. Several questions have been raised about the possible effects of the vaccine on fertility. And I will add anecdotally, from being in a newsroom and hearing from the community all over the place, we have a lot more questions from women who either are pregnant or they want to be pregnant, or they think they may be at some point, or are breastfeeding, who have a lot of concerns about the vaccine, more so obviously than men who would not be one carrying a child. What do you guys say, or can you speak on the possible effects of a vaccine on fertility? And anyone can answer.
as per the CDC, there's currently no evidence that any vaccine, including COVID-19, cause any fertility problems. They currently are not recommending that women get a pregnancy test prior to receiving the COVID-19 vaccine. And they recommend also that if you are trying to conceive, you do not need to wait in relation to the COVID vaccine. But, you know, like in any vaccine, they're very, very carefully monitoring all the side effects.
Yeah, I think that's spot on. You know, what I would add again, these are individual decisions, and best taken in context with your personal physician to help you look at the evidence and the data, and to help you arrive at the decision that's best for you. The American College of Obstetricians and Gynecologists have come out fairly strongly supporting vaccination in women who are pregnant or thinking about becoming pregnant, or who are breastfeeding after pregnancy. And I would recommend that any woman who has these questions go to that website, or talk with your obstetrician or your gynecologist to help you look at that information, and again, have that conversation about what's right for you. I mean, I think that's, to me, if there's any one theme out there, is go to the source information, talk to a trusted individual, you know, your provider, your physician, or whomever, to help you make decisions.
I'd just like to add that what we are seeing unfold now with the pause on the authorization for the J&J vaccine is not something that should detract from our confidence in the vaccine process. In fact, it's an example of the process working the way it is supposed to work. We are monitoring the side effects of the vaccines among the people who've received them, and the data is being used to make decisions. And this is true of every pharmaceutical product that is available on the market, even those that didn't go through the emergency use authorization that the vaccines went through, but those that went through a longer process. It is normal to learn from the wider population that takes or that utilizes a product, and to develop our knowledge as we go in an incremental fashion. And that is how science works. It is sometimes frustrating that it is that incremental process, but what is happening with the J&J vaccine right now is transparent, and it is the process doing its job. And I hope that people will see that watching that unfold is an example of exactly the kind of monitoring that Dr. Little and others were just talking about.
So I'm extremely online, and there seems to be, and I've seen it over the last few days, especially since the J&J announcement, there seems to be a fairly organized vaccine disinformation effort specifically around fertility, around menstrual cycles, some of it coming from people who label themselves doctor but aren't actually doctors. And so there is a lot of bad information out there about this that seems to be pretty coordinated right now. And so that's something to definitely watch out for your sources.
Always research who you're getting the information from. Look into those doctors' names. If so-and-so doctor says something on Facebook, if someone's uncle got sick and you don't know that person, look into and just see if it's some string that has a lot of followers intending to cause harm. Yes, that's good advice. Another question from Teresa. Curious as to whether, this is a good question, curious as to whether boosters can cross the two types of vaccines. For example, if one gets a Johnson & Johnson, can you then get a booster from another vaccine, especially if you have concerns over the J&J shot?
Yes, there's active clinical trials for crossover from one vaccine in the first shot and a second vaccine, a different vaccine in the second shot, and whether that will actually produce more effective immune response. Those trials are new and they are not complete, but that's definitely a option that's being considered as to whether that will produce better immunity.
Okay, and I just want to ask as a final question again, in case we already asked this and we already answered it, but for anyone else to answer, because there are multiple, half a dozen questions about UNCC starting again, July 4th, excuse me, July 1st with normal operations. Are there concerns for students? Do you have to get the vaccine to be back? If you don't know how long the vaccines are going to protect people on campus, let's say it is only 6 months or so, what about that efficacy? How does that play a role altogether? Again, we're asking, we already answered this once, but I want everybody who's still watching this right now to hear it from the panelists again, the UNC Charlotte specific response.
Thus far, the university is saying that vaccines will not be required. However, those who receive vaccines are asked to document whether they have received it, and that information will be used to help with our tracking on campus. We'll exempt individuals from completing a daily survey and may exempt them from some random testing that will be happening.
Okay.
And so with the program that we run, the wastewater program, what we have heard is that we will be continuing monitoring at some level, not necessarily as much as we've been doing, but they are aware that COVID doesn't completely end on July 1st, and the university will be watching out for risks to students at various levels.
There are dozens of questions. We said we were going to wrap up at 2:30. We're going to have Catherine Tinglestad, the head of Atkins Library's Digital Media Literacy Group, to have some concluding comments. If you've asked a question that wasn't answered, the team is going to try and go through them and give you specific responses and at least incorporate all of these ideas and questions that you guys have into the FAQs that are put out. Also, Dr. Chen sent me a message saying he apologized. He had to get off at 2, but he will personally go through all of the questions and comments. And remember, he was expert in social media, among other things, and respond to any that were directed at him. So I know all of our panelists are grateful for the questions because, as we all know, that's why we're here today. There has been so much information out there over the past 12 months, and trying to find the right information and the fact-based information can be difficult. So thank you all to the panelists so much. I personally have appreciated the past 90 minutes in a huge way. I'm going to go write about it on Facebook, and it will be fact-based. So hopefully you can see that post. Thank you all. And Catherine, please take it away for the concluding comments. And again, an honor to be a part of this all. Thank you very much.
Great, thank you so much. Hi, everyone. My name is Catherine Tinglestad, and I'm the head of the Digital Media Literacy Group at Atkins Library, which is the group that planned this event with the help of our colleagues at University Communications. I'd like to thank you, Molly, for doing an excellent job moderating this timely and really informative discussion. And a big thank you to all of our panelists who've been so very generous with their expertise and their time. I hope this conversation illustrates for all of us the importance of having access to reliable information on a topic as critical as this one is. As the head of the Digital Media Literacy Group, I can speak to the fact that we all need strategies for managing and evaluating online content that we read each day. There are people who unknowingly share inaccurate information, while others intentionally create and share false content to achieve their own agendas. We all need to be vigilant in committing to read online information critically, asking questions and challenging content. And we must also accept that our own biases and beliefs, whatever they may be, can make us uncomfortable with factual and reliable information. The Digital Media Literacy Group at Atkins Library has developed lesson plans, resources, and other content that can help you learn and teach about media literacy. So if you're a faculty member, please contact a subject librarian at Atkins Library for help with creating assignments and teaching classes that focus on this important topic. And again, thank you to everyone who participated today. This was really fabulous.